Thank you for joining us today. We will be discussing an important topic entitled Essential Emergency and Critical Care. This is a very important topic that links in well with the WFSA's annual theme for 2025, which focuses on anesthesiology in health emergencies. My name is Zainub Jooma from Chris Hani Baragwanath Academic Hospital in Johannesburg, South Africa. My co-moderators for today are Prof. Bernd Böttiger, who is the head of Department of Anaesthesiology and Intensive Care Medicine from the University Hospital of Cologne in Germany, and Dr. Julia Weinkoff, who is an intensivist and anesthesiologist at Abbott Northwestern Hospital in Minneapolis from the United States of America. Prof. Böttiger, I'll hand over to you to run through the agenda and some of the housekeeping rules.
Thank you very much for this nice introduction. I am from the medical faculty of the University Hospital of Cologne, currently in holidays in the beautiful country of Spain. It's very sunny outside and I'm enjoying that very much. We have more than 2,000 pre-registered participants from 157 countries in this webinar, and we're expecting a lot of them to join us. We have 3 talks. The first one is about 20 minutes, second one 15 minutes, and the last one is about 10 minutes. And at the end, we have 25 minutes for discussion. So overall, the duration of our webinar is 1 hour and 15 minutes. We have already received more than 150 questions in advance, and we are also open for online questions during this webinar. You will receive, if you like, a certificate of participation. No CME points possible, but a certificate of participation if you stay with us for at least 60 minutes. And the webinar is recorded so we can spread it over the WFSA channels in the future. And with this, someone else needs to take over to introduce the first speaker, please. Thank you.
Hello. I'm Julia Weinkoff from Minneapolis, Minnesota, where it is currently -20 Celsius. Very cold here.
My God.
Yes. So first, we're going to have a talk on an introduction to essential emergency and critical care by Professor Tim Baker. And then Dr. Karima Khalid will talk about operationalizing essential emergency and critical care. And then Dr. Lopez will talk about building capacity and training for EECC. So first, I'm very pleased to introduce Dr. Tim Baker. He's an associate professor in the Department of Global Public Health at Karolinska in Sweden. He also works as a consultant there in anesthesia and intensive care. He has affiliations at the London School of Hygiene and Tropical Medicine and Queen Mary's University in the UK, as well as Muhimbili University in Dar es Salaam, Tanzania. And if you've ever happened to have the pleasure of meeting him, you will have instantly noticed his enthusiasm and energy for improving global health services and emergency and critical care. He has had consultancies with all the major global organizations working on this, including the WHO, UNICEF, World Bank, USAID, etc. And he's led the development of this concept of essential emergency and critical care and is the principal investigator on the provision of essential treatments in the Critical Illness Project. So he will start by giving us an introduction to this concept. Go ahead, Tim.
Thanks so much, Julia, and everybody. It's an honor to be here presenting to you all today. So I'm going to talk to introduce this concept of EECC and talk a bit about how it's relevant in health emergencies. I'm going to start with a couple of cases to set the scene. We start with a pregnant lady. Many of you will recognize cases similar to her one. So this is a lady who arrives to a health facility unconscious. She has a seizure. And she is diagnosed very promptly by the health workers as having eclampsia, and the correct treatment is done. She has an emergency cesarean and a healthy baby is delivered. And post-operatively, she's sent to the ward. All good so far. Sadly, when you come to work the next day, you hear the terrible news that she changed condition on the ward overnight and passed away. Second case is a young man, aged 25, who was in a road traffic accident, and he arrives to a health facility covered in blood. Similar to the first case, he gets good diagnostics, is diagnosed as polytrauma, taken for a CT scan and taken in for a laparotomy and for surgery. Similar to the first one, postoperatively on the ward, sadly doesn't make it through the night. And the third case, a little boy also arrives to a health facility. This little boy is unconscious with a high fever. And it has a rapid test for malaria, diagnosed to have severe malaria, and receives the state-of-the-art treatment in that facility for malaria and is admitted to the ward. And I think you see the pattern emerging here. Unfortunately, by the next morning, he had also changed condition and died overnight. And the big question for all of us is why do we think these patients died? What was it that led all three of them to change condition overnight and die? And the standard reflection is maybe there was something in the quality of the care, the quality of the obstetric care, the trauma care, the malaria care. But as the cases were presented, you could see that actually they received very good diagnostics and very good definitive care for their pathologies. So maybe instead of that, the problem was their illness severity. They became critically ill and no one noticed that they were deteriorating. Or maybe they didn't receive the most fundamental care of critical illness when they needed it. This is what we mean of as EECC. So many of us here today are anesthesiologists or allied professionals, and I would argue that the defining attribute, the thing that brings all of us together in this room today, is that we are the experts, the absolute best at caring for critically ill patients, whether it is perioperatively, whether it's in an ICU, in emergencies, whether it's on the ward. So we use the term critical illness all the time. That's the thing that we are best at. But critical illness is a bit slippery to define. So a few years ago, we came up with this definition, trying to focus then very much on illness severity. Can be any patient from any underlying condition as seen in the picture on the right. And once a patient gets to an illness severity where they have a life-threatening state, where their vital organs are dysfunctional and they have a high risk of death, they are now critically ill. So it's a very broad definition based on severe illness severity. The resources for caring for patients with critical illness vary very much. As we all know, the pictures on the left at the top show a critical care unit in Sweden where I have worked, and the bottom left shows another ward where I've worked this time in Tanzania. And you can see the difference in level of resources. They also depend on the level of hospital. University hospitals have more resources than regional, who have more resources than district. And even on the time of day that we're talking about, daytime hospitals have more facilities than nighttime. So this slide is showing that we need to be aware of the resources we have and that critical care, which can be all of this care of critical illness, is not the same as the high-tech ICU care you see on the top left. We've just completed a study across Africa called the ASIOS study, and it's just been accepted in the Lancet. So in the next few weeks, we will see this article being published. So I just wanted to very briefly show the results of this study to highlight the importance of critical illness and critical care. So in this study, investigators across the continent examined all adult patients in all wards and units in the included hospitals, looking for the prevalence of critical illness and whether the patients died within 7 days. Also investigating what care was provided and what resources were available. 22 countries were included with a total of 180 hospitals and almost 20,000 patients. And the age of these patients was young, only a median of 40 years. Now, the headline results are that if we think of the prevalence of critical illness, 12.5%, which is 1 in 8 of all hospital inpatients, were found to be critically ill. So a very, very large burden of critical illness. It's not isolated to just the few patients on ICU, because 2/3 of these critical ill patients were cared for in general wards, spread out around the whole hospital. If we look at the care, the fundamental care they were being received. So 48% of those who were hypoxemic, who had respiratory dysfunction, were being provided with oxygen. 54% of those with a circulatory problem were receiving intravenous fluids or vasopressors. And 49% of those with a low conscious level were lying in a recovery position or having an airway intervention. So roughly half of the fundamental critical illness care was being provided that should have been. In terms of mortalities, 1 in 5, 20% of those who were critically ill died within 7 days, compared to only about 2% of those who are not critically ill. So being critically ill was had a very strong association with 7-day in hospital death. The take-home message really from that study, how it fits into this talk, is that critical illness is much more common than most policymakers and hospital managers think it is. The patients are very sick with a very high risk of death, and the fundamental treatments are not being provided. So there's a potential for improving care and saving lives. And this leads us to the concept of essential emergency and critical care, which is a concept, but also a systems innovation defined as the care that all critically ill patients should receive in all hospitals in the world. So it's a normative concept. It's like a human right. This is the baseline, fundamental, foundational care that we really should provide to everybody globally, the kind of minimum standards of care within critical care. It can be conceptualized as this: as you go up in this picture, care gets more and more expensive, and along the picture is showing the different locations where care can be provided. So the essential emergency and critical care is this big bottom layer that can be provided everywhere. As you go up, care becomes much more expensive, and you get to the things like intermediate care and then advanced emergency and critical care in intensive care units, where things like mechanical ventilation, dialysis and ECMO are. So what EECC, this bottom layer, is trying to do is really transform the way we are thinking, conceptualizing and providing critical care throughout the world. We don't have to focus on this top, the spiky bit. We need to give this foundational level first, and then we can build on that. What is in this care? What's the content of EECC? Well, we did a Delphi consensus with over 200 experts from all over the world, mostly from low and middle income countries, from very varied specialties, coming up with the definition, the content of what is contained within EECC. And these experts came up with 40 clinical processes. I'm not going to go through them all, but they're the ones you would expect, really. Things like conducting triage, using vital signs, providing oxygen, providing fluids, doing safe handovers, but not the level of things like blood transfusion or CPAP, which are very valuable treatments, but were seen by these experts as being too advanced for EECC. And to provide these 40 clinical processes, hospitals require 66 resources. So those were also defined, things like pulse oximeters, IV giving sets, the things that hospitals need to be able to provide safe and effective EECC. Implementation is ongoing. Karima is going to talk more about that. But from one study a few years ago to see whether EECC type activities could improve outcomes was this study also from Tanzania, the Vital Signs Directed Therapy Protocol, which was a piece of paper, a task sharing protocol in an intensive care unit, whereby nurses would take the vital signs, work out if the patients had severely deranged vital signs, so the red levels of derangement, and were then permitted to provide simple therapies like oxygen and IV fluids. And when this was introduced, what was seen was a very large increase in the acute treatment when a danger sign was identified, and mortality for patients who were hypotensive was significantly reduced. So it seems like EECC implementation strategies can improve outcomes. The cost of EECC, some health economic work has been done and found that for every healthy life year saved, if EECC is introduced, there is a cost of $14, which is seen by health economists as very highly cost effective and similar cost effectiveness as many other well-established public health interventions such as anti-malarial drugs or emergency obstetric care. So for us as anesthesiologists, as critical care practitioners, we can say we have this foundational level of care that has population level significance and can be comparable to other global health and public health interventions. So we fit within that sort of dialogue. What are the benefits? What can we say and try and argue to policymakers? What can be our advocacy messages? Well, EECC is clearly low cost, and it appears to be a cost-effective approach to this large quality gap, these need of treatments and critical care that we have seen. It has equity in its core, so it is attempting to give the care to everybody. No patient group is left behind. It will make our system prepared and resilient for public health emergencies. We'll come back to that in a minute. It will improve care and outcomes both in big hospitals, but also in primary healthcare and in general wards of district hospitals. And interestingly, we can think of it as well as a way of increasing the impact of scaling up emergency medical departments, emergency units, and ICUs. So all over the world now, there are increasing calls for intensive care units, emergency medical departments. But if our wards are not providing this foundational level of critical care, our patients will not receive the good care before ICU, and they will not be able to receive good care after ICU. So we will receive patients in intensive care in a moribund state, and we will find it difficult to discharge our patients back to the wards. There's also a very large scale up of oxygen taking place all over the world. And EECC contains oxygen, absolutely, but it is also adding on the other foundational parts of critical care to oxygen. So it means that rather than just saving a hypoxemic patient by giving them oxygen and then seeing them die of some other fundamental cause, EECC could ensure that they get the fluids and the airway protection, the other necessary items of care to keep them alive. And governments, particularly following the COVID-19 pandemic, have really invested in this critical illness space and emergency disease space, and are now talking a lot about pandemic preparedness and things. And EECC is really, can be argued, is the way to capitalize that and protect these very large investments that have taken place. So we are not used to this as doctors and health professionals, but we should use these sorts of economic arguments to get traction with governments. To visualize this a little bit, this, I would say, is where we are currently in our health system. Because our health systems are not emphasizing critical care, they're not emphasizing EECC, we have a very fragile situation. EECC is narrow at the bottom. The rest of our hospital care is balancing on this. It doesn't require very much for the whole system to collapse and the patient not to receive good care. We want the system to look like this, with a very solid, broad-based foundation. Make sure patients always receive these basic things, life-saving things, this oxygen, these fluids, things that we all think of as human rights. And on top of that, we can then build the hospital care. We can build our surgery. We can build our C-sections. We can build our ICU care. That would be the sign of a healthy health system. Just to focus a little bit on public health emergencies, which is one of the focuses of this webinar. So COVID really made all of us aware of this, but it's not the only type of public health emergency. You can get terrible traumas like this train crash in the picture, the awful fires taking place in the US at the moment. There's floods, there's earthquakes, there's wars. All of these things lead to a very large surge of critically ill patients. And what can be seen if you have a system which is not resilient, is not prepared for that, is a situation similar to the one we all witnessed in India and many other countries in the COVID pandemic, when the system quickly became overwhelmed. There was too many patients requiring oxygen, too many patients with life-threatening disease. The system could not cope. and that led to vast amounts of unnecessary deaths and suffering across the world. If we instead could build a resilient, prepared system that was providing EECC all the time, when a surge of critically ill patients like that would happen, here in the picture is a kind of image illustrating this. You have the hospital care, you have all of your hospitals sitting there like a tree, but the roots of EECC are weak. When a pandemic hits, or it can be a different type of crisis, a financial crisis or a human resources crisis, the tree is not stable, it would fall over. If instead you've built up this foundation of care, a very strong root system, then when the pandemic hits, when some other public health emergency hits, your hospital remains standing. It can scale up the oxygen, it can scale up the essential emergency and critical care, weather the storm, carry on providing the patients this foundational care, and avoid the unnecessary deaths. So my last slide. What are we talking about in this presentation? We've said that critical illness is common. Actually, it's strikingly common, and it's a neglected problem. We think that 1 in 8 hospital inpatients are critically ill, a far larger proportion than most people would think. And there's a substantial unmet need of critical care. So these patients are not receiving the first line foundational care that they need, the oxygen, the fluids, the EECC. If we want to have a resilient health system that is prepared and can manage any sort of health emergency, then we should have a health system that is based on a foundation of EECC, so that the crisis that comes along cannot knock the system over. And if we can do that, if we can provide EECC to everybody, there's a very large potential, possibly up to 1 million lives every year, large potential for averting deaths. Thank you very much.
Thank you very much for that comprehensive introduction to EECC and just conceptualizing how important it is to basic care that we provide to our patients. I will hand over to our next speaker, Dr. Karima Khalid. I was very privileged to meet her and Tim Baker at a Congress recently in South Africa. Karima is also a member of the Intensive and Critical Care Medicine Committee of the WFSA. She's also a lecturer, researcher, and consultant anesthesiologist in critical care. She's very passionate about EECC and has been involved with its development since inception, including with research and disseminating findings to improve the care of critically ill patients. She's also involved in the Tanzania's Ministry of Health Emergency Response Committee and has contributed to the country's EECC strategic plan and integration of EECC principles into the national guideline on oxygen therapy. So she's well positioned to give us this talk on operationalizing EECC in resource-limited settings. Thank you, Karima.
Thank you, Zainub, for that very nice introduction. And yeah, the word operationalization is actually quite difficult to pronounce. Yes, thank you, team, for setting the ground for me to continue on about EECC. So it's my pleasure to speak to you on operationalizing EECC in resource-limited settings like my own. And as Tim just introduced to us as he ended his talk, we can be faced by multiple emergencies or disasters at any point in our careers or in our work in the world. So EECC provision forms a lifeline in these unforeseen crises and medical emergencies and natural disasters. And they help us in maintaining a seamless and effective critical care system in these challenging situations. Us as anesthesiology providers are very important people who play a really important role in these health emergencies, managing these emergencies, because we're people who are actually called for to handle these kinds of problems all over the facilities, within the facilities and outside of facilities. So what do we really need to do to ensure that our systems are resilient when we are faced with such crises? One of the most important things to do is to make sure that EECC is integrated into our health system, to make sure that we are always ready to cater for any emergencies that could happen in our health systems, and that our systems are ready to take care of these emergencies. So to be able to do this, we need to have a multifaceted strategy. First of all, I'll take you through some of the things that we can go through to ensure that EECC is in place in our health systems. We have a network of EECC that I'll talk about a little bit in details. We also have EECC champions, people who can speak and advocate for EECC at any level. We also have EECC hubs that one needs to form in their countries that will help advocate for EECC. We need to involve the government to form policies. We also have to do a lot of research to get some evidence and to work on that evidence to improve things. We also need to engage specialist societies and other stakeholders and find ways that are suitable for our local environment to be able to implement EECC in our environment, advocate for improvements, train people on the provision of EECC, and procure the necessary resources that are needed for the provision of EECC. So I'll take you through some of the strategies that we use in Tanzania as an example to ensure that EECC is in place in our country. So first of all, we have the EECC network, and this is a platform for collaboration. We are actually very active in research, in advocacy, in policy development and training and implementation of EECC. We have more than 1,000 members globally from more than 50 countries. And it does bring together global stakeholders to promote and implement EECC around the world. So it's experts in the health field, funders, donors, governments, and other NGOs that are involved in health. All those stakeholders are brought together in this platform to promote and implement EECC. It also facilitates generation of knowledge around EECC and engages people at local, national, and global levels for EECC. There's involvement of governments, there's donors, NGOs, and other stakeholders, all for the sake of implementing and advocating for EECC. So as you can see on this map, we have members of the network from all over the world. Right now, if you know anybody from Russia, if there's anybody from Russia here, you're welcome to join the network, because we don't have people in Russia as yet. So the vision of the network is for all critically ill patients to receive EECC in all hospitals in the world, so that no patient dies from a cause that EECC could prevent. And from the other thing that we do as a network is create champions who can advocate for EECC. So we've had these champion workshops, around 4 of them so far. Mostly all of them have been held here in Tanzania, because we have a kind of developed a hub in Tanzania that is quite active, and it also represents the global part of EECC. So we have had champion workshops that have involved local and international champions from all over the world. And the objective really is to create champions who are equipped with the expertise and abilities to lead EECC-related initiatives within their hospitals, within their regions and countries, and also at a global scale. So in Tanzania, currently we have 60 champions, and we have almost more than 20 global champions also, all spread all over the world. And we have a set of super champions, and these are people who have been really active in advocating for EECC, speaking for EECC, implementing EECC in different regions, in different parts of the world. And they have become now, they have reached at a level higher than just being the champions. So what next? After joining our network and maybe attending a champions workshop, the next thing one can do is create a national hub. And the purpose of the hub is to promote EECC in the countries where somebody is based. Currently, we have hubs in different countries. For example, here in Tanzania, Cameroon, Sweden, Malawi, we have USA, Nigeria, Rwanda, Mongolia, and others. And once you have formed a global hub, so the hub will consist of people who have the same thinking as you in terms of EECC. So it's a point of gathering people who are like-minded, and this can vary from clinicians, admin people, policymakers, government stakeholders, and other stakeholders in the country who will be interested in improving the care of patients who are critically ill. And once we have identified these people and have come together and discussed EECC, the next point is to identify local priorities for EECC implementation. And with this, establishing partnerships with the government and professional bodies and other stakeholders to ensure that everybody is in line with the same thinking and they're supporting the implementation of EECC in the country becomes very important, because without their support, it's not going to be easy to implement EECC. Once we formed our hubs, it's very good to start to start small for getting a good impact. So one can pick one facility to implement EECC in. If you're working alone or if you're having a small group, it's easier to implement this in one facility. And we have a rapid assessment tool that can be used to identify gaps within the facility. Once these gaps have been identified, then implementation strategies can be developed. For example, simple things like emergency boxes, which store and ensure that essential supplies that are needed for EECC are always in place in all service provision points in our facilities. Having checklists that are used for triaging, like the VSDT chart, and checklists for our resources to ensure that they're always in place whenever needed in our wards for our patients, and training people on the very essential skills that are needed for EECC, procuring resources that are not in place. And these resources, as Tim has stated, they're very, very basic resources that need to be there in place. But we have found that there are some, most of them are missing. For example, they are studying in Tanzania, and it showed that resources are available actually in our facilities. Almost 80% or 90% of the resources that we need to provide EECC are actually available in our facilities, but they're not in place where patients are. So when you go to the ward, the readiness in the ward falls down to around 54%. So they're there, but they're not where the patients need them. So when implementing this, and ensure that all the service provision points, the wards, have the resources that are needed. So whenever a patient becomes critical or an emergency happens, then that patient can be taken care of. And with that, we can also develop research agendas that can help us produce more evidence that will help in improving the service that you're providing and improving the EECC that is being provided in the facility once the implementation has started. So as I talked before, stakeholder engagement is really important. So this doesn't only involve hospital leadership, but it also involves the healthcare providers themselves. They have to have a buy-in into this EECC and understand that it is important and it's time and life-saving. So people normally don't like being given new things or more work to be done. But if they are made to understand that EECC can actually save lives and save their time because they will not need to rush around, then that would be very helpful for our providers. And also involving the government and other stakeholders, because without their buy-in, we'll not be able to get the resources and the funding that we need to be able to provide EECC in our facilities. So as an example, Tanzania, we were able to do all this. We advocated for EECC in Tanzania. We disseminated the findings that we had from our, oh, sorry. Are you able to hear me? Good. So we were able to submit our findings to the government and other stakeholders, and the government bought into the importance of EECC, and the National Strategic Plan for EECC was developed by Tanzania, both in the mainland and the islands of Zanzibar. And right now, we're in the phase of implementing this or operationalizing EECC in Tanzania. And the goal of the strategic plan is to provide the vision and the national guidance on the EECC and its rollout. And this will happen in different areas to identify key gaps, prioritize, and find out the interventions that are needed. So we are doing this currently. We have an 18-month plan that aims to operationalize and integrate EECC, including oxygen therapy, in all health facilities in 5 regions of Tanzania mainland, plus Zanzibar. And this is a government plan, which is supported by UNICEF and MOHAS, and is based on the National Strategic Plan, and it's an 18-month program, and it is programming to scale. So you're going to start in these 5 regions and Zanzibar, and then later on come up with the best strategy for implementing it and post it, and this will be upscaled in the rest of the country. It involves all primary healthcare facilities, including dispensaries, health centers, and district hospitals, and there's a possibility of adding the district and regional facilities. And our aim is to avoid vertical programs. So we are going to ensure that it is integrated into other programs and not work as a standalone program on its own. It has 3 pillars. So the plan right now that we are implementing in Tanzania has 3 pillars. One of them is disseminating information on EECC and developing training modules and job aids and reviewing our health management information system to ensure that they are capturing information on EECC so that we can be able to trace how EECC is performing and make improvements. And our next pillar is assessment and rollout of implementation research and implementation strategies. So we're going to implement, we have done a rapid assessment of our health facilities, and we are currently developing implementation strategies. We're going to have 3 different implementation strategies that will be implemented in the 6 different regions. And at the end, you're going to see which one works best. We will cost this one, that one we find to be the best, and then this one will be upscaled for the rest of the country. So these are the regions that are involved, and we're going to pick 2 districts. We have picked 2 districts in each facility, and our target is any person becoming critically ill in that population who needs to receive oxygen or EECC. And they're targeting all public primary healthcare facilities, and there's a possibility of involving the regional facilities. So this is, as I have stated before, we are having now we have done the dissemination of all the EECC information all over these 6 regions. We have developed capacity building and training materials. We have developed indicators for the HMI system that can capture EECC. And right now we are in the phase of its implementation and implementation research. We hope to conclude this work by the end of this year and gain insight that will help us scale EECC in Tanzania, but also get some learning that will help us scale this up in other parts of the world. So the aim actually is to build resilient health systems by ensuring that EECC is integrated during these peace times when there is calmness in our facilities, when we're not having crisis. This will help us strengthen our daily healthcare services and prepare for emergencies and pandemics when they happen. So resilience is the key to saving lives during crisis. So to conclude this, operationalizing EECC, we can say it's feasible as we are doing it already in Tanzania and impactful even in low resource settings. Global and local collaborations are really essential to ensure that it happens. Small targeted actions lead to systemic changes. So we have to start small and grow as you go along and make bigger plans as you proceed in the work. We encourage everyone to join us in this movement through our network. We have the EECCnetwork.org, so anybody can join the network and join any of our working groups and form a hub in their countries, and that will be able to implement EECC in any part of the world. So our take-home messages. My slides are not advancing somehow.
Thank you. If you can hear us, Dr. Khalid, thank you for giving us a sense of how things are going in Tanzania with EECC. We'll move on then to our third talk by Dr. Rodrigo Lopez. He's an anesthesiologist in Chile at Pontificia Universidad Católica de Chile. He has a master's in public health from the London School of Hygiene and Tropical Medicine and a PhD in biomedical ethics and law from the University of Zurich. And he also is a PhD student in innovation economics, government, and sustainable development at Maastricht University. He supports a number of NGOs. In fact, I think he's in Sudan right now working, is that right? And has done missions to many other countries, including Chad, Ecuador, DR Congo, and others. So take it away, Dr. Lopez. He's going to talk now about building capacity in order to deliver EECC.
Thank you very much, Julia. Thank you very much, team and Karima, for this introduction. Now it's going to be easier for me to explain the activities that we're doing to spread the word and how to train teams to perform all this EECC program. I don't know if it's working. Yeah, so I'm going to take some concept of capacity building and how to train people. It's not that easy as we sometimes believe it is. Then the program that we're developing, the EECC face-to-face training program, and another program, the online training resources that the consortium has. Moving slowly, conflict of interest declaration, I have to say, of interest, I'm a visiting professor at Pontificia Universidad Católica de Chile, senior anesthetist in an Italian NGO called Emergency, and now I'm based in Sudan. That's why I have a poor connectivity, and I'm an anesthesia advisor for another NGO called Lifebox. So, think about capacity. The first question is, what is capacity building to the particularity? And we think about that, to give skills to people, to teach them to do something. It's about how the system behaves. It's not only people, not only teams. But can you hear me or not well?
Yeah, not that well.
Okay, I'm gonna
keep
speak
going.
slowly. I'm gonna speak
Yes.
slowly. Okay, so capacity building is not only about teaching skills or concepts or theoretical knowledge. It's mostly about how to change a system, how to provide all the necessary things, skills, resources, etc. We're going to talk about that later, to change the way that the system reacts. And including part of the system is people's behavior. And it's not that easy to change people's behavior. We tend to have like fixed patterns of behavior. So if we decompose behavior, we need to have two things mostly to explain or predict the way we are gonna act. First, we need to have an intention to action. I want to do this. I want to achieve that. I want to, etc. And we need to have the resources. Resources, broadly speaking. So material resources. If I want to give oxygen to a patient, first I have to have the intention to do it, the knowledge, etc. I have to have the oxygen and oxygen mask, for example. But I also, resources means also to the non-material resources like protocols, hierarchies, part of these resources. So we need these two things: an intention to action and the enablers, material and non-material resources. And the intention to action, we have, there are many different theories to explain behavior, but according to one of them, we need three things: knowledge, theoretical knowledge. I have to know what to do. Skills, I have to know how to do the thing that I want to do. And attitudes. So I have to have a positive vision of, for example, oxygen. I have to feel empowered to do it. And one of the issues is that most training programs focus on knowledge, which is good. People should know theoretical things. Some courses focus on skills, which is important as well. Anesthesiologists, we must know how to intubate a patient, but attitudes are often forgotten. We don't think that, we pretend that just explaining how to do something, people will do it. And that's not always the case. Regarding resources, it's really difficult to get resources from a training course, but something that we can provide participants is advocacy skills, to be able to empower them and to give them the skills to advocate for the material resources they need and to promote the change. And thinking about skills, developing capacity building, we have to keep in mind that we're not children, we're adults, and the way that adults learn is different from children. That's why we don't use the word pedagogy when we're talking about adult learning. We use the word andragogy. I think andragogy is a little bit male-centered, but that's the word that we use. Sorry with that. And some of the principle of this andragogy is it's important to keep in mind the motivation, why adults want to learn. The motivation most of the time is external for children, so the score, they want to have a good grading score, that's it. For adults, we don't care that much about these external motivations. We need to value the knowledge that we're going to get. Purpose. We're going to invest time and energy in a course. Why? It must be meaningful to us. And this is why it has to be pertinent for our own lives. If you offer me a course on photography, I will be happy. But I'm not a photographer. So I'm not sure that I'm going to spend hours and days learning about photography if I'm not going to do it. If it's something that it's related to my life and my professional life, then it's more likely that I'm going to be really engaged in this training program. It must be problem-centered, not talking about theories and the way the world should be, but a real problem that I faced before. And that's why it should be based on people's experiences. We're adults, we have been many times working in the hospital, we've faced many situations, so it's important to talk about those experiences, good and bad experiences. And based on those experiences, it's going to be much easier to build this new knowledge and to actually change behavior. Another really important concept is that for adults, learning is a social phenomenon. We can learn things by ourselves, reading in a book, we all have done that. But if you want to change the way we behave, it's much efficient if we do it in a group. And it's much efficient if we do it in a group that work with me. That's why Karina was talking about this network. That's the purpose of having a network, not just to say that I'm a part of a network, but to share experience with the rest of the people, to be more motivated to continue this endeavor, and to make it real in a way. So that's why being social beings, it's important to recognize that, and learning must be or foster social experiences. Having all these concepts in mind is that we developed this EECC face-to-face course. It's a 3-day face-to-face course targeting not only anesthesiologists, not only nurses. This course was made for the whole team: nurses, clinical officers, doctors, anesthesiologists, surgeons, whoever care for sick patients. And the idea is not only having individuals, but teams. So people from a hospital, nurses, clinical officers, the whole team is the idea to bring them to participate in this course, to have this social experience together. It was developed in collaboration with UNICEF, Muhimbi University in Tanzania, and the governments of Tanzania and Zanzibar. The aim is to improve the quality of care provided by healthcare workers, to improve outcomes and save lives. And it has 5 modules. First, what is EECC? More or less what Tim explained. Identification of clinical illness assessment, how to identify a patient who might benefit from these practices. Third, care of critical illness, of situations, how to take care of airway, how to take care of breathing, how to take care of circulation, issues that we might face in this assessment. Some general process in EECC, communication, for example, it's not part of the ABCDE approach. That's why we included another topic on general processes. And finally, scenario training to put in practice all these skills, all these concepts that we have learned, and to actually socialize a bit. This course, I'm going to show you the planning for course development. So each topic had a content developer, and you can see there, for example, the description of each content developer, and there was a reviewer, and they work as a team. So the content developer develops some materials, the reviewer review those materials, provide feedback, and there was a back and forth work between these two people. And when this team decided that the topic was good enough, it was reviewed by the second reviewer. And this was done topic by topic. After the 5 topics were completed, we tested this program. The first pilot course was held in Tanzania, end of October, if I'm not mistaken. And now we're doing the final edition of the material, getting all the feedback from participants. We're working on the final version. And this course will be validated in a workshop with the Tanzanian government in a couple of weeks, if I'm not mistaken. And this is a picture of the first pilot course of this of the EECC face-to-face course. After this validation workshop, the course will be launched in Tanzania, and then it's going to be available for everyone interested in being part of this initiative. And this is how the course looks like. So as I told you, 3 days, registration, there are some tests, of course. There are, of course, coffee breaks. There are some lectures, for example, what is EECC lecture, theoretical content. But for example, then identification of critical illness skill station to work on skills and discuss, to gather all the experiences that the participants may have had during their practice, and from then build on knowledge. Then lunch, identification of critical illness, again, skill stations, discussing things, practicing skills, and then simulation to put together the theoretical knowledge, the skills, and again, to discuss and learn together how to improve the quality of care that we provide. Coffee, sum up, then second day, recap, and we start by how to take care of critical conditions, critical care, airway, lecture, and then skills and discussions. Coffee, lecture on breathing, skills on breathing, then circulation, lecture, and so on. The final day, we have the general process lecture, communication, for example, teamwork, important things if you want to improve the quality of care and if you want to be prepared for any emergencies. So we have to improvise in those situations, and working as a team is the best strategy to be more resilient. Skills station on general processes, and then again, simulations. There is not everyone will have the chance to be part of this face-to-face course. Ideally, yes, but it's difficult. So there is an online course. I'm sorry, I'm not a technological guy, but here is the the site, you can find the course there, and this is how it looks like. This course has been accredited by the ACCME, the ACPE, and the ANCC. It has more or less the same models: introduction, what is EECC, identification of critical illness, critical care, airway, breathing, circulation, reduced conscious level, other care, the general processes, and final assessment. Here, it's difficult to, of course, discuss. The idea is to follow this course as a team. So I would strongly advise you to, if you're interested in this course, take it as a team. So spread the word and do it together. And then it's going to be easier for you to have this social experience of learning, discuss the topics, discuss the content, and then to plan together how to implement these concepts in your clinical practice. My take-home messages. It is possible to implement effective training programs to build capacity in EECC. There are a number of training programs available online, and the face-to-face course is almost finished. And it's important to train teams, not individuals. Otherwise, we won't change the way we behave and things will stay the same. If you want to change the way we treat patients, we have to think as a team. And I think anesthesiologists, we have a really good opportunity. We work with everyone. We work with pediatricians, with the surgeons, with emergency care doctors. So we're really transversal. And that's, I think, why we anesthesiologists could help to spread the word and implement these courses all over the world. Thank you very much.
So great. Thank you very much, Rodrigo, for this very nice presentation. I think we had a huge amount of extremely interesting presentations and suggestions. And we are now coming to questions and answers. And I have the privilege to chair the question and answer session a little bit together with Zainub and Julia, who were monitoring the questions coming live into our webinar. And I would like to start with a sample of questions that was always appearing already up front, asking, is EECC under the umbrella of the Department of Anesthesiology, or is it in the hands of anesthesiologists? And why should anesthesiologists be primarily involved in EECC? And maybe we can have a brief answer from all our speakers, starting with Tim, a very brief answer on that.
Thanks so much. Nice question. I tend to think of EECC as being patient-centered, patient-focused. So it is the patient who requires this foundational life-saving care, and actually to be quite agnostic about which department or which type of health worker is providing. It can be a nurse, can be a doctor, can be any health worker in any specialty. I would, though, argue that the strongest advocates for care for patients with critical illness tend to be anesthesiologists and critical care practitioners. So in that way, I think it is our duty, it's our profession's role to be the ones who are speaking up for EECC and trying to strengthen it worldwide.
Okay, thank you very much, Tim. Karima?
In addition to what Tim has just said, I would say that as anesthesiologists, as Tim correctly said, this involves the patients more than who is providing the care. But also as anesthesiologists, we tend to be the people who are called in for any emergencies that happen everywhere in our facilities. So it is our duty to ensure that those who are with our patients all the time are able to provide this care to the patients, the nurses in the ward, the junior doctors in the ward, whoever is taking care of the patients is able to stabilize the patient so that when we are called in to provide our expertise, the patients are in good, at least have been handled well and have been given the basics that they need. And also the same thing when sometimes we are working in ICUs and theaters and we stabilize our patients and send them to the wards. And when they reach the wards, they don't get the very basic care like oxygen or fluid that they need in the wards. So we as anesthesiologists have done a very good job in our theaters, in our ICUs, but then our patients, we lose our patients in the wards because they're not getting this very basic care. So we need to advocate and make sure that this care is being provided in our wards to ensure that the work that we're doing is fruitful and that we're doing meaningful work to our patients. Thank you.
Thank you very much, Karima. And Rodrigo, what is your answer to that question?
Of course, I agree with the Karima and team, but I think it's important that, again, it's centered on the patient and all the healthcare professionals caring for critical patients should be able to provide EECC. Anesthesiologists were not available all the time. That's why it's a responsibility for everyone, not only doctors, also nurses and every healthcare professional working in a hospital and eventually facing one of these patients should be able to do it.
Okay, thank you very much. And now, Julia and Zainub, do we have questions from the live chat?
Yes, we do have quite a lot of questions. I will start with Dr. Lopez. If you can just give some idea on how the live courses can be accessed for people outside Tanzania. I know some information has been shared on the chat already for the online courses that are available on the EECC network website. But if you can just share the live courses and then how can people train other people in their institutions on EECC?
So the face-to-face course is not officially there yet. We're almost there, but there are some steps that we're still missing. So the course has to be validated first. So with the validation, then it's going to be kind of tested again in Tanzania, and then it's going to be available for everyone. The best way to contact the organization is the web page that you have shared already. And then there are discussions going on regarding the TOT, the training of trainers. The idea to have this course is important to spread it easily. So I think the WFSA has a lot of experience in similar courses, the SAFE courses, for example. And the idea is to replicate more or less this model. So people get trained, we have local trainers, and then they become trainers and they can run the course independently. But yeah, so there's still more work going on regarding the face-to-face course. More news will be available soon, hopefully.
Thank you. Julia, do you have any questions on your side?
Yes, maybe I think this one might be for Dr. Khalid. I think we heard quite a bit about upper level interventions that are happening to start EECC, kind of countrywide things and course-wide things, but it seems like there are a lot of people who may not feel like they're strategically positioned to start initiatives like that, but who are very interested. Can you maybe give some concrete examples of things that folks could do to start doing EECC in their maybe district hospital, just in their PACU or in their emergency room or in their wards? Do you have a couple tools or recommendations for things that people could do to get started?
Thank you, Julia, for that very good question. I'll start and maybe Tim can add more information. But yeah, it might not be easy for somebody to start at a large scale like the one you're doing in Tanzania right now. But once somebody has signed up and into the network and learned a little bit more about EECC, it's as we said, easy, basic things that you're doing every day. But also it's best to become a champion, understand it, to understand it better. And then you can start, what we recommend for people to do is we share our assessment tools. So you can assess the area that you're working to see that you have the resources that are needed and the clinical processes that are needed to be conducted for in EECC are being done or not presently being done. And if there are gaps, then you address those gaps accordingly. So this could be, we have a basic, we have a comprehensive tool of assessing our facilities, and we have a rapid assessment tool that we can share with everyone, and they can quickly find out how their facility is at presently in terms of EECC, and how to improve things. We usually leave it to the facilities themselves, because it's not a one tool fits all kind of thing. So people have different ways of improving their strategies in their countries or in their facilities, but we can provide some tools that are available to anybody who needs to do this in their countries. And these resources will be available, are available on our website, and some of them can be shared through our network. Team?
Karima,
Anything else?
There is another question coming in, which is related to the topic. What are the minimum resources needed to provide EECC? You have shown us in your presentation this trolley. So what is your answer to what are the minimum resources needed?
So the resources that are needed, there are 66 resources that are needed. These cut across 8 different categories, like infrastructure, human resource, equipment, consumables, guidelines, routines. So these can be shared. They are also shared on our network, and we have a study, the Delphi study that team shared, which outlined the requirements for EECC, the processes and the 40 processes and 66 requirements that are needed to provide EECC. And these are very, very basic things, as we said, like face masks, pulse oximeter, blood pressure, measuring equipment, oxygen, fluids, and the like. Yeah.
Okay. Thank you very much. Questions coming in by live chat?
There's 2 questions on data collection in low resource settings who want to implement EECC. Maybe Dr. Khalid, you can give us some idea on how low middle income countries can go about standardizing their data collection, what kind of tools do they use, and what minimum data they need to operationalize EECC in their settings.
So you can start as small data as possible within a facility or even within a ward, using this rapid assessment tool that we have developed, just assessing, for example, do you have a pulse oximeter, which is functional? Do you have a blood pressure machine? Do you have oxygen in your ward? Do you have people who have the knowledge to provide this care, like putting on oxygen, understanding what a reading of maybe 80% means, and when to provide oxygen, when to provide fluids for a shock patient, and using things like the DSCP chart to guide their protocols or their management of patients. So the minimum you can collect data on is these resources that we have identified, and you don't have to do it with all the 66 resources. If you're doing in a small place, you can do all the resources. But if you want to collect data on an extensive area, then we have the rapid assessment tool, which has worked quite well. We have used it in Tanzania. It has worked quite well in informing us where the gaps are. It has parts of the availability of resources within the facility, readiness in the wards, meaning that are these requirements actually available in our wards. And we also did some, we checked some of the clinical process to see what is being done to our patients. We actually also use simulations within the facilities, in-situ simulation, to assess the clinical processes that are being done, or to understand the processes that are happening in the world in terms of EECC, and also the knowledge of our healthcare providers in terms of EECC. So those are the tools that can be used to collect the minimum data that is needed to provide EECC. We could also do some interviews, interviewing they say in a facility, the leadership, the healthcare providers themselves, to see where the gaps are. And that can help also. Yeah.
Excellent. Thank you very much. What else is in the chat, Julia.
A couple folks pointed out that they feel that the term emergency and critical care gives the impression that this care is advanced, or that these are things that need to be done in the ICU. Maybe this is for you, Dr. Baker. Can you emphasize why this needs to be called critical care? Why critical care can happen outside the ICU, to give people a kind of clarification why this is critical care?
Yeah, we've actually had long discussions in the team about the name, and this name was the one that we ended up choosing, and it's because emergency care and critical care are well-established terms that we chose them. It means that people understand what sort of things you're talking about. And then what's important for us is the word essential before it. So you can think that EECC is actually an intersection between two fundamental ideas. One of them is this idea of managing critically ill patients, so illness severity that we discussed earlier. That's the one that you might be right is often thought of in ICU, but we are trying to challenge that concept because it is intersecting with this concept of essentialness, which is an idea of the most fundamental, foundational kind of first line care, which could be in other fields as well. You can have essential pediatrics, essential obstetrics, and so on. So where essentialness meets emergency and critical care, you have EECC. So we think it's quite a useful term from that point of view.
Well, and I think the impression I'm getting too is that critically ill patients happen everywhere. They are not just in the ICU. The point is to detect critical illness in people in your examples who were on the wards or in the recovery room or anywhere, or out have not gotten to hospital yet. And so it is critical care of critically ill patients, but the early detection happens before they get to the ICU, correct?
Absolutely. So EECC should be everywhere. Just to say as well, it should also be in the ICU. So I have worked on some ICUs where we are providing some quite advanced care, but the EECC, some of those aspects are still being missed. Maybe the airway is not clear, or the oxygen runs out, or the ICU doesn't have an emergency box. So if something would happen, then it isn't ready. It isn't prepared for that sort of emergency. So I think EECC is absolutely outside the ICU, in the wards and elsewhere, but also within the ICU.
Yes, and many of our questions talk about how do we implement this in low resource settings, but this is happening everywhere in high and low resource settings. I just had a patient on call 2 nights ago who was on the wards who died because they were not getting this even in a high resourced setting. So this applies everywhere for sure.
Thank you very much. We have 2 minutes left. And I have a final brief question with the request for a brief answer to Rodrigo, to Dr. Lopez. So what about children? Are children also focused in your courses?
Yes, there are some modules explaining the difference between adult and pediatric airways, for example. So we talk about adults and children as well. We've thought about that, and they are included in the course.
Excellent. Thank you very much. And you all have seen there is an invitation to join the EECC network, and there are online courses available, and further information will come out through the WFSA YouTube channels. And sorry we need to come to an end. We have a very intensive discussion. We have a lot of more questions, and the final words are going to Zainub.
Thank you, Prof. Böttiger, and to Dr. Weinkoff for co-moderating the session with me, and to our panel of experts on the topic who have covered it from what EECC is to how you get it into action in your specific facilities, and the courses that are available to build capacity in your centers. With this, we'll close the webinar. Please look out for other WFSA webinars from the Intensive and Critical Care Medicine Committee that will be shared in due course, and start registering for the WCA in 2026 in Marrakesh. Thank you very much.
Thank you very much.
Thank you, Zainab. Thank you, everyone. Bye.